All right. Hi, everyone. I'm Marguerite. For those of you that don't know me, I'm one of the fifth year residents. I have spent all 5 years here. It's pretty wild that it is coming to an end. So I picked a topic today that I spent a lot of time not only growing up with because of I grew up in rural Appalachia, so I was surrounded by rural healthcare disparities growing up, but also I spent a lot of time on this topic in medical school. So I'm going to kind of go through it's going to be a little bit of a hodgepodge, and I wish I could talk about all the things I want to talk about today, but I'm going to try and hit the highlights for you. So I don't have any disclosures. This is just a thing that I care about a lot, and thank you all for being here and for listening to me. So a little bit about me. Dr. Dudas already kind of went over some of it, but I grew up in Covington, Virginia, which, as you can see on the map here, is really, really close to the state line of West Virginia. Interestingly enough, I grew up about 25 minutes east of the Greenbrier and about 20 miles south of the Homestead, which was pretty interesting growing up in a, I would say, rather low income community with two very large resorts about 30 minutes in the west direction and in the north direction. I had a lot of high school friends and a lot of family friends that wound up working at these places, but I have never stayed at any of those places, nor had any of my friends. That gives you an idea of the kind of the landscape that we're dealing with. I graduated from Roanoke College, which is a small little liberal arts college in Salem, Virginia, in 2014. And then I went to Virginia Commonwealth University for medical school. It's actually the alma mater of my dad, who got his nursing degree there. While I was at medical school, and I'll spend a lot of time kind of talking about my experiences, I was in a program called I2CRP. That stands for the International Intercity Rural Preceptorship Program, which I had to write essays to get admitted to it. It was an honors program that focused on spending 3.5 years of your clinical training focusing on all types of healthcare disparities. So that included, I didn't get any international experience, but I spent a lot of time in urban settings. I spent some time doing women's health. I spent time in LGBTQ and trans care. I did a lot of healthcare disparity work as a part of this program, starting from my second semester of med school. And then obviously I wound up here for the past 5 years, which West Virginia comes with its own host of healthcare disparities, as we all know from the patients that we treat. And then I will be going on to St. Louis for my vascular surgery fellowship in August. So just to give you a little bit of background about some of the places I've been, some of the things that I've seen, and why I'm talking about this. So in medical school, one of the first experiences I had was at the Crossover Healthcare Ministry downtown, which is on the south side of Richmond. It was actually primarily served Spanish-speaking patients at that time because the Medicaid expansion had taken effect in Virginia later. And so we saw that more of our urban population that we had been seeing actually was able to get in to more established practices. So we saw a large undocumented population there. Also, while I was there, I spent my first 2 years going at least once every 2 weeks to the free clinic. During my at the end of my second year, we had to do an immersion experience, and I got to meet the princess of the Mattaponi Indian tribe in the Powhatan region of Virginia. That was the same tribe that hosted, or that Pocahontas was a part of. And that was a really moving experience because I think, in school, we learn a lot about, what our relationship was with the Native Americans. And then we gave them reservations and like everything was fine. I think at least that's how I was taught in grade school. And that's not the case. I learned a lot about the differences between having state recognition and federal recognition between Indian tribes and what that means in terms of healthcare access, food access, land ownership. There's a lot of things that go into Native American populations that I didn't know previously. One of the biggest experiences and one of the things that I credit some of the most intense and meaningful experiences was when I did my ambulatory rotation at Whitman Walker Health in Southeast DC in Anacostia. And also we had one clinic site that was further north. At Anacostia, I've spent most of my time doing urban, true urban underserved care, HIV care. We did see an LGBTQ population there and focused on transgender care as well. I actually had a Latina transgender population that I took care of on Wednesdays at our other site. And they specifically came to see my preceptor, because they knew that they could trust her, which is very, it's a very big deal to find a provider you can trust as a gender sexual minority. It's a huge deal, especially someone who's helping you with gender affirming care. But she also spoke Spanish and she spoke fluent Spanish, and the relationship she had with those patients was really inspiring to me. I thought for a long time I was going to do primary care, which is why I started doing all of this. But as I moved into my medical education, realized that I liked surgery, I liked being able to fix things, and that there was still a role for all of these healthcare disparities in our patients because it impacts our patient outcomes. It impacts what surgical planning we might be able to do for patients and what their access to resources may be for post-operative care and those things. So I spent the rest of my time at VCU, mostly in inner city Richmond. I had one rural experience that I don't think even compares to here. And then of course I've spent the past 5 years here, where, as we all know, we get referrals from Western Maryland, Southern Pennsylvania, all over the state. Sometimes our patients are coming from 3 hours away just to get our care. Several uninsured patients, not a whole, I've seen a few undocumented patients here, but mostly just Appalachian poverty. The type of the patients that we treat here are very similar to the people that I grew up with, and I have a very soft spot for them. So now that you know kind of why I care about this, I'm going to talk a little bit about what we're going to talk about today. We'll go over the basics, the stuff that you guys learned in population health. And if you were like me, weren't as excited about it until you had a reason to apply it or knew how to really apply it. The next thing I wanted to talk about is policy and local government, and why you should absolutely care about these things that are happening, even if they don't directly affect you. We are going to talk about some racism and some other uncomfortable topics because I think it's very important to talk about these things. I also, I sent a video last night. I know a few of you have texted me. Thank you for those of you who watched it. It doesn't matter if you didn't, but I do want to talk about adverse childhood experiences and childhood trauma in the context of healthcare disparities, because I think understanding that mechanism really ties it all together. As far as my disclaimers go, again, this is mostly based on my experience in my realm on this topic. It's my interests are academic, clinical, and personal. And secondly, and most importantly, some of these topics are going to be uncomfortable, but discomfort brings growth, which is why I think it's important we talk about it. So, basic definitions. I know that most people have seen this picture. I think it's a great picture breaking down the difference between equality and equity. So when you look at health inequity, when you look at the World Health Organization's definition and the Center for Disease Control, the World Health Organization defines it as systematic differences in health status, health outcomes, or distribution of resources between different population groups, causing significant social and economic costs to both individuals and society. So it's not just the individual that's being impacted. For the CDC, they really target that these are preventable difference in burdens of disease, injury, violence, or opportunities to achieve optimal health that are experienced by populations that have been disadvantaged by their social or economic status, geographic location, or environment. And some of the differences, particularly are ethnic and racial differences. These disparities are present if you need control for other factors. So that's really important to keep in mind going forward. So this is specifically talking about cancer, but it gives a pretty good overview of different groups of people who have disparities in healthcare, racial and ethnic minorities, which includes, like I said, Indigenous people, women. Well, I'll save my soapbox for a little bit later on that one, but care differences between women. It's no secret that most medical textbooks and most medical research was done for men. So even now in 2023, we are still learning differences in how women present with different diseases. People with disabilities, experience healthcare disparities, people with limited English proficiency in this country, gender and sexual minorities, and then of course the rural populations and populations that have other geographic limitations. So these are the headlines that we frequently see when we talk about healthcare disparities in America, and they are staggering and very bothersome. Black women have 3 times the maternal mortality risk as white women, even when controlled for other factors. Native Americans' life expectancy, which was already the lowest out of all of our the ethnic groups studied in this particular study, fell from 71 to 65 years during COVID. That is not matched, with the exception of the non-Hispanic Black population, almost fell about the same distance. But we don't see that across other differences or across other groups. And then when you take an honest look at things like cardiovascular disease, diabetes, renal disease, stroke, African Americans are more likely to die early from early ages for all causes, especially as they age. So the big question, is why? Why does this keep happening? And that's really what I want to start diving into. And of course, I can't talk about healthcare disparities without talking about our state. West Virginia has one of the lowest life expectancies in the United States. That's very important to note. So also why? When you look at the breakdown of our access to healthcare, we have 21 critical access hospitals, a lot of federally qualified health centers, but those don't necessarily those aren't necessarily inpatient treatment centers. And then when you look here at all cancers, when West Virginia has one of the highest cancer rates. Sorry, 1 second. You can see based on geographic data, where the highest incidences of cancer are. So again, that begs the question of why, what's happening in these areas, what is specific to these areas that are driving up cancer rates? Is it access to care? Is it environmental? Are there other things that are going on? So pretty boring definition of the social determinants of health. I remember sitting through population health and these are all the things that we learned for the test, but it's important to look at these and apply them. And I think it's a good exercise to apply them to a community you care about or a community you know well. What is the education access and quality like? I remember we went through, it was my first year of medical school, and we were sitting in table groups, and I was like, let's look at my hometown. And my hometown is like 5,000 people. At the time, the national average for percentage of people who had a bachelor's degree or higher was around 22%. And I was like, let's look at my hometown just for fun. Education access and quality, 8%. 8% of the population had a bachelor's degree or higher. That's less than half of the national average. When you look at healthcare and quality, we do have a hospital in my hometown that did have some multidisciplinary care, but that is slowly going away, and patients are having to travel farther. The neighborhood and built environment, economic stability, social and community context. Is your neighborhood safe? Is it safe for you to walk to work? Is it safe for you to go buy groceries? Those are things you need to live. Do you have social support? Are you experiencing racism or discrimination or other things that add stress and impact your health outcomes? So I also wanted to talk a lot about policy, and I'm going to focus specifically on Richmond here in the next few slides, but I want to make sure that everyone knows that this is broadly applicable. Slavery was a large chunk of time. When we look at our time frame from 1619 to now, that's the majority of the time of our country. That is not a small thing. It was not that long ago that we went through the civil rights movement. It was not that long ago that we went through desegregation. Women couldn't even have their own bank accounts until 1974. So that sounds like a small thing, right? But think about some of our elderly patients who maybe rely on their husbands or are now widowed and don't know how to manage their finances. Like these are smaller things that we don't think about every day, but on the grander scheme of things, understanding how history has impacted our social structures tells you a lot about how patients or what hurdles patients might have. Roe versus Wade was overturned. I was very sad. I think a lot of people were. In total, the total ban states, I know it's a controversial topic, but safe access to abortion care is absolutely imperative in preventing maternal mortality. And the less access we have to safe health care, the worse the outcomes are going to be for women, especially women of color. Right now, the hot topic is gender affirming care. Kids are transgender and other gender sexual minorities are at a higher risk of suicide, of depression, of substance abuse, and other chronic comorbidities. And I know there's a lot of debate surrounding this topic, but the more we stigmatize our fellow human beings, the more that it impacts their health outcomes. It's really important. And I watched several patients. And so this is a thing that's very near and dear to me. I watched several patients at the very beginning of my month at Women Walker who were walking into a nationally renowned clinic for LGBTQ care, who were still terrified to talk. We're terrified, we're afraid they were going to be stigmatized. We're afraid we were not going to give them compassionate care because of who they were. And this was a safe place for them. It was amazing providing gender affirming care, watching people start to feel like themselves, watching the depression dissipate. And I think that that's a thing that we have to keep an eye on as our policy moves forward in the United States. The Affordable Care Act came with its own roller coaster of pluses and minuses, but overall it's been a good thing in getting people access to healthcare. The Medicaid expansion or lack thereof, depending on where you're at. West Virginia did expand Medicaid. It took Virginia a while to expand Medicaid, but thankfully they did. Virginia previously, at least when I was in my first years of medical school, was one of the hardest states to get Medicaid in. And Medicaid, just for our medical students, if you don't know, I'm sure some of you do, is for people under 65, typically who have either low income or a disability. In Virginia, you used to have a disability and you would never qualify on income alone. Medicaid dollars are also very important for things like funding residency positions, funding like our hospital and other government hospitals. So the Medicaid expansion in states that accepted it has made a big difference in getting healthcare access, especially to rural populations. And then Indigenous peoples, I talked about a little bit, but I really wanted to hammer home the difference between federal and state recognition of tribes, because it really does make a difference in what resources folks get. One of the things I learned when I toured the Mattaponi reservation is that the state owns the land. So no person that lives on that reservation owns any of their land. When you're applying for loans, when you're applying for jobs, when you're looking at assets like that, all of those small things add up. There's no federally qualified healthcare for state tribes just in Virginia. The Pamunkey was able to get federal recognition, which was a big deal because Virginia freaked out about casinos and everything. But in reality, it was a big push by the Pamunkey tribe because they would have sovereignty over their land, but also they would get benefits like healthcare. They would get more federal benefits that would help them survive. I bring this up again because I think the timeline is important. It's easy for us to say, oh, that was then. That's not our problem now. But it is our problem now because it wasn't that long ago. And society is still changing from the changes that we have made in the past. We are still growing. And especially as we move forward to talk about some of or racism, urban planning, it's very important to keep how fresh it actually is in your mind. So I learned about redlining during one of my I2CRP seminars in Richmond, Virginia, and I wanted to scream off of the tallest building when I was there because I was like, how did I not know any of this before or put it all together? So I'm going to share it with you. Redlining is started during the New Deal era, although there were some after the Emancipation Proclamation and in the early 1900s, this was still happening. Around 1916, the Federal Housing Authority was like, we can't strictly segregate based on, or we're not supposed to do this based off of race, but we're gonna find a way to do it anyway. And that's basically what happened. So with the federal housing shortage and the New Deal, in 1933, funding was provided to white, middle, and lower class families to help them get back on their feet during the Depression. This excluded people of color. People of color were typically pushed into housing projects and free housing, usually in already low resource areas of the city. In 1934, the Federal Housing Administration was created, and they worked with the Homeowners Loan Corporation, which basically took a look at the city or the area where the property, or for every city, every area, the Homeowners Administration made a map, or the Homeowners Loan Corp made a map. And on this map, there was color coding. You could get a grade A through a grade D. A was the least risky investments. These were predominantly white neighborhoods, neighborhoods with a lot of businesses. The overall value of these zone neighborhoods was high, and it also meant to investors, this is a safe place for you to invest, although it was flawed logic. They looked at things like the age of homes, the average home value, proximity to industrial areas, and then the other category was integrated. The presence of people of color was noted as a sign of imminent decline, even in thriving neighborhoods. This is a map of Richmond. This is an article that was featured in, I think this was the Atlantic. The Times did one as well. You can see all of the red line districts in Richmond. These were predominantly Black neighborhoods, several of which during the 1900s, as I'm going to talk about, were actually very successful neighborhoods. Richmond had its own Black Wall Street, and this was Jackson Ward. So Jackson Ward is on this map right here, close to downtown. It was a very, very affluent and thriving Black neighborhood in the 1920s, 30s, and 40s. It was also frequently referred to as the Harlem of the South. Despite all of this, despite the job opportunities, despite people thriving, because it was a neighborhood of people of color, it was still given a D rating. Going back to think about what that D rating actually means, it means that that neighborhood property value is lower than that of the A's in the white neighborhoods everywhere else. So when eminent domain comes into play, something we all learned about in high school and civics class, which is the power of the government, federal or local, to take land for public use. We learned they can do that, but they have to pay you. That's the catch, they have to pay you. So what happens if you're in a low income neighborhood and the value of your house that they're going to pay you for to tear down your whole neighborhood to build a highway? What is that going to buy you? If you are on the cusp and you are doing fine, your property value, your house gets taken, your property value is limited. That limits where you can move next. So I want you to think about that. I want you to think about that in context of the Richmond Housing Authority, which of course at its original foundation had no one but elite white male business members. They proposed the Richmond-Petersburg Turnpike, which is now Interstate 95, to go through Richmond. Actually, the Virginia General Assembly, to their credit, held a public referendum on this twice. It failed twice, both or with support for the rejection from both Black and white citizens. Didn't matter. They went ahead and did it anyway. In 1954, they announced that they were going to build the turnpike, and they were going to build it through Jackson Ward. They destroyed 1,000 homes. They created a block-wide barrier, canyon cut between the neighborhood's historic center, blocked a lot of pedestrian pathways, blocked 31 streets, and eliminated all sidewalks in a thriving Black neighborhood. It'd be great if that just happened once, but it happened over and over. And it's not just in Richmond, but in Richmond, it happened in some other neighborhoods. There was a neighborhood called Navy Hill over here in the downtown area, actually pretty close to Jackson Ward, where the biotech park and some of my medical school buildings are now, or are now. This had a school that rivaled white neighborhoods. I can't remember the specific story, but I remember there being like a spelling bee or some competition where I think like the Black students won. That caused a big deal. Navy Hill, also given a D rating, even though it had great schools and jobs, was torn down to build the biotech park. This happened again in Fulton, except the business plan never came to fruition. Fulton was also a rising Black neighborhood after both Jackson Ward, Navy Hill had been torn down. And this was torn down to build an industrial park that never came about. And this happened, this wasn't unique to Richmond. I mean, Richmond was the capital of the Confederacy. Richmond's got its own bad history. It's a thing we talked a lot about at VCU. But it didn't just happen there. It happened in urban centers all over the United States. And that's really important to put into context, because what that does is it creates hyperdense pockets of poverty that are stagnant because people can't get out. When you continue to take down neighborhoods, even if it's by eminent domain, even if you're paying people their property value, if you have limited mobility anyway, you are going to get pushed into the next pocket of poverty. And that cycle continues generation by generation. So, things to think about moving forward. We did get the Fair Housing Act in 1968, which tried to undo some of the damage that had been done. However, as you'll still find on some articles, if you dig far enough, that there are still deeds and covenants attached to houses with racist and other xenophobic language. Even if they're not legally enforced, for some reason, they're still part of the deed. I personally can't imagine being a person buying a house with one of those deeds or covenants and feeling safe. Additionally, I don't have as much time to talk about this, but I did want to also talk about and skim the surface of the long history of mistrust between minorities, people of color, and healthcare providers. During the HIV and AIDS epidemic, there were a lot of doctors that turned the other way, the public turned the other way, and that created a lot of mistrust in the LGBTQ community. Tuskegee was terrible. It's not limited to that though. Again, for all of the great things that VCU did for me, it has some bad history, and the Medical College of Virginia made sure that we all knew where their training doctors got their cadavers from, because they found a mass grave close to where they were going to buy one of their parking lots. So slaves were frequently experimented on. Other minorities, disabled persons, that we think about Nazi Germany and, the sterilization experiments and all those things, but those things happened here too. Henrietta Lacks and her stem cell line that she didn't get credit for. And then I had heard some rather personal stories from the Mattaponi tribe about both suicide by cop from some teenage from a 13-year-old boy that she knew because he knew that if the cops got called, they would probably shoot him. To other unauthorized experimental care happening in the past like 30 years to some of our Native Americans. At least this was specific to them. So what does this mean when we talk about early adversity? The video I sent last night talks specifically about adverse childhood experiences in an isolated kind of context. And at least 2/3 of you sitting in this room will have at least one adverse childhood experience. That can range from physical, emotional, or sexual abuse to neglect. If you had a parent with mental health issues, a parent who was addicted to substances, a parent who was frequently in and out of the house, incarcerated, a parent living with significant mental illness. And then we talk about our expanded ACEs. So again, is your neighborhood safe? Is it safe for you to walk home at night? Are you living in foster care and being bounced from home to home with no stable environment? Are you being bullied at school? Are you dealing with racism? And these have real significant impacts on the developing brain and body of children. And scientifically, it makes sense, right? I'm going to show part of the clip that I had sent last night because I think Dr. Harris does such a wonderful job of explaining it. But if your body is under chronic stress all the time because your living situation is unsafe, you don't have food security, you don't know where your next meal is coming from, you're sick, you are a 12-year-old taking care of yourself, your cortisol is constantly going, and that causes genetic changes in your own genome. It changes the way that our genes are read, transcribed. It changes our health outcomes. Let me see if this will work. I'm not going to show the whole thing, just a clip.
The developing brains and bodies of children that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, "Dr. Burke, have you seen this?" In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC. And together, they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you know, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand better than we ever have before how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior. And that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed. So for me, this information threw my old training out the window.
And she goes on to talk a little bit more about her work, which is incredible. I encourage you to watch the full thing if you have time. Sorry. But this brings me back to these things. If we know that living in an unstable environment, undergoing stresses of both childhood instability and also societal stresses, especially on our minority populations, if we know that all of that adversity is going to impact their health, then we have to do what we can to make sure we are maximizing ways to help with economic stability, help with education access and quality, especially us as doctors and healthcare professionals, making sure we understand where our patients are coming from. And I think that understanding, especially if a lot of our own West Virginia patients have had hard backgrounds, have probably have high ACE scores if you looked into several of our patients based on the poverty level of Appalachia. So the only thing I ask of you guys is to put that in context when you think about your next patient, especially your next difficult patient. And really to put what we know about how, especially how stress impacts the body, changes our DNA. And when you think about that over all of the time in the United States, where we have had marginalized populations, how that generational trauma has built. And are we surprised at some of the healthcare differences that we see? I think it's really important to understand this topic for that reason. So I think that's all I have, but I'm happy to take any questions. Thank you. As you go to St. Louis University, studying vascular surgery and doing your fellowship, you know about the research talks about Blacks getting a higher rate of amputation. How can you as a physician impact other vascular surgeons in your community about these therapies that we see every day? Yeah, that's a great question. So Dr. Woodbury asked, as I move on to St. Louis, talking about the higher amputation rates in Black populations, and how do I kind of spread this knowledge to my, I guess, my vascular surgery community? Thankfully, I've had actually a lot of conversations with my faculty at St. Louis about this topic, and they were really excited when I talked about it during my interview. Because they have some research that is actually they have one of the professors that's very focused on health outcomes. So I think the biggest thing that we have to do, at least for me personally, is to continue to talk about it, because it's an uncomfortable topic, right? Nobody really wants, like, we talk about racism, we talk in this country a lot of the time, and people start arguing because they're like, I'm not racist, but it ignores the entire point of the systems that this country has built that still exist. And I think for me personally, bringing light to that, also taking extra time with especially my minority patients, and doing education, taking a look and seeing, like, how can I help you get to your appointments? What other factors, are in your way? When I was at one of the things that I admired about my family medicine experience was that we had 30-minute visits for our complex because all of our patients in the Southside Clinic were complex. And we actually got to take the time to dive into some of those things. And so I think talking to your patients, understanding where they're coming from, understanding their home background, and trying to lead by example is, I guess, the way I would answer that question. Yeah. Awesome. Thanks.
Thank you all. That concludes our Zoom activities for today.